Hi students, welcome to the question answer discussions of the OBS and Gynae part of the UPSC 2026 exam. This was such a clinical paper. I'm feeling so excited to take this discussion because it is exactly what we keep telling you, that read around the topic. They've asked you so much of clinical questions, but every question has a lot of anatomy, biochemistry, physiology in it. So yes, let's see how much they can test you even when they ask you only clinical questions. So yes, let's see the first question. Which of the following set of vaccine is contraindicated in pregnancy? So yeah, all of us know that the live vaccines are contraindicated in pregnancy, and that's why the vaccines here, the measles, mumps, rubella, that set of vaccines, and the varicella is the one which we don't give in pregnancy at all. So the answer to this question is C, and these are the vaccines in pregnancy. Safe in pregnancy are the tetanus, diphtheria, toxoids, the hepatitis B, influenza, meningococcal vaccine, and the rabies vaccine. But yes, the contraindicated vaccines are the measles, mumps, rubella, varicella, like it came in this question, and the BCG. Of course, the anthrax, Japanese encephalitis, polio, IPV vaccine, the yellow fever, hepatitis A are given on special recommendations. So yes, you must know this list properly, and this was that rather simple question which came in the exam. Let's move on to the next one. Consider the following statement regarding the chorionic villus sampling used for prenatal diagnosis. Now, chorionic villus sampling means basically the placental biopsy. When you put a needle into the placenta of the early pregnancy, then you can take out the chorionic villi, the fetal villi, and you can do the karyotyping. And once you do the karyotyping, you can also do the genes on these chromosomes. You can do the genetic assessment also. So that's why it's a diagnostic test. Although it is invasive, it can cause abortion. So generally we do it between 10 to 13 weeks of pregnancy. So what are the statements which are correct? It is done between 15 to 20 weeks of gestation. That's wrong. Amniotic fluid studies give earlier diagnosis. No, amniotic fluid is done generally in the 16th week onwards. So 16 to 18 weeks is generally when we do amniotic fluid studies or the amniocentesis. The early amnio is done 13 to 15 weeks. So this is not correct. Chorionic villus sampling is earlier, not amniotic fluid sampling. And limb reduction deformity is low when CVS is performed after 9 completed weeks of gestation. This is correct. So limb reduction defect, we always say that CVS should be done after the 10th completed weeks. We say 10th to 13th week. Before 10th week, you can have limb reduction defect. So if they have said after 9th completed weeks, I'll say that's a correct statement. Injection anti-D 50 micrograms should be administered along with this procedure in an Rh negative mother. Any invasive procedure in a Rh negative mother, you should be giving, even for an amniocentesis, or you're doing an external cephalic version later in the pregnancy. All of these you should be doing a anti-D administration, because there can be some transplacental bleeds. So 3 and 4 look correct to me. So the answer for this question is D for Delhi. All right. Now the next question is on the active management of third stage of labor. As per the WHO recommendations, all of the following may be given for active management of third stage of labor except. So the active management of third stage of labor, all of you know that when the anti-shoulder of the fetus delivers, you should be giving oxytocin, and after that you should do delayed cord clamping more than 60 seconds. You can do early cord clamping also, which is written in Williams obstetrics. But we do delayed cord clamping in our country because we want more hemoglobin for the newborns. After that, you do a control cord traction. Once the baby is delivered, you do a control cord traction of the placenta, and then you do a uterine massage, a gentle uterine massage, not a bimanual compression. So these are the steps which are standard, and these are mentioned in front of all the labor rooms of all the major medical colleges in the country and all the district hospitals. Now, WHO comes out with updates very regularly. Now, they do not become practice in our colleges immediately. As and when they become practice, we shall inform you. So, active management of third stage of labor, this is what has to be done. And the least important component of all the 4 things which I told you is the delayed or the early cord clamping, because it does not affect the incidence of PPH. We do delayed cord clamping. If you read your Williams obstetrics, they have written early cord clamping which should be done. So, please remember, we do what practice in our hospitals, that is what is coming in your exams. Always remember that. That's why when you do an internship, you must spend some time in all the clinical subjects and see what is done. That's why these questions become very easy to answer. Now, oxytocin can be given when the delivery of the anti-shoulder happens, which is the drug of choice which we do, and methyl augmentin can also be given, and this is what I have given all my life as the active management of third stage of labor, because I rely much more on this drug than oxytocin. But I'm not saying that this is a drug of choice for your exams. Maybe this is the drug of choice as you become an obstetrician. use more methyl ergometrin. That's a personal advice to my friends who are going to become obstetricians later. But yes, the drug of choice for exam purpose and what is recommended by WHO is oxytocin. You can give methyl ergometrin, methogen also. You can give tablet misoprostol. You can give it sublingually, and you can also give it rectally. Now, carboprost cannot be given. So that is the answer to this question, because that causes sudden tonic contractions, and that is reserved for the management of PPH rather than for the prevention. Now, the next question, consider the following statements regarding the onset of labor. Now, this is where a lot of physiology has come when we are talking about these clinical questions. So, they are asking about the onset of labor. What are the biochemical events which are happening? So, statement number 1, alteration in the estrogen-progesterone ratio results in prostaglandin synthesis and onset of labor. Correct? Because the estrogen primed increase in the gap junctions between the myometrial cells, that is what is going to increase the prostaglandin synthesis. Let me read this statement for you once, and then you'll understand better. See, when the patient is reaching term, there is increased production of the DHES, dehydroepiandrosterone sulfate, and this in turn converts to estrogen. Now, what does this estrogen do? This increases the gap junctions between the myometrial cells, and that produces more prostaglandins, and you know prostaglandins will induce labor. Now, that is one influence of induction of labor. Then oxytocin receptors will increase. Mind you, I'm not saying the amount of oxytocin. So, oxytocin receptors increase in the decidua. The lining of the uterus is known as endometrium, and in pregnancy it is called decidua. It increases more than 100-fold at term. So, this is because of the increase in estrogen and due to the estrogen distension late in pregnancy. Why do the oxytocin receptors increase? That's the reason I'm telling you. So, when there are more oxytocin receptors, the circulating oxytocin which stays, yes, please note, the circulating oxytocin stays at 25 picograms per ml, but the same oxytocin has more effect because there are more oxytocin receptors. That's why the uterus starts contracting. So, these are the events which lead on to the onset of labor. Then, in addition to this, what happens at term? There is increased production of cortisol, which causes lung maturity of the fetus. That's when the fetus decides, now my lungs are mature, this is the time when I should deliver. So, what happens at term? There is increased production of corticotropin releasing hormone from the hypothalamus of the fetus. Fetal hypothalamus, please note, I'm not talking about the maternal, the fetal hypothalamus, and there is increased production of the placental corticotropin releasing hormone. So, this along with the increase, this actually causes the increased ACTH production, you know, the corticotropin releasing hormone from the hypothalamus stimulates the pituitary to make more ACTH, and you know ACTH will cause more conversion of cholesterol to cortisol, the breakdown events which form the cortisol. Cortisol will cause lung maturity. That's why these are the events which are happening at term. So, what do we say? There is alteration in the estrogen-progesterone ratio resulting in increased prostaglandin synthesis. That is a correct statement. Decreased fetal production of dehydroepiandrosterone sulfate. No, there is increased production of fetal dehydroepiandrosterone sulfate. So, that is a wrong statement. So, going by the choices we've been given, statement 1 is true and statement 2 is wrong. Statement 1 is true and the statement 2 is false. So, C is the answer for this question, right? So, if you are reading, you don't have to read big books in obstetrics to understand the methods of onset of labor. Yes, parturition, I've taken a separate chapter discussion when you read the PW app, but even if you read your Genong, you'll understand the basics of the onset of labor just by reading the 2-page discussion in Genong. That's a very crisp and fine discussion on the process. Correct. Let's go and see the next question. Consider the following statement regarding the WHO labor care guide for labor monitoring. Thank God, they have done exactly what I keep telling you in all my practice sessions, that if they ask you about the WHO partogram, the partogram which is still used in all the labor rooms across all the medical colleges is the modified WHO partogram. Now, if they ask you the labor care guide, which was introduced sometimes in 2018, when then it was recommended in 2021, and it's a very extensive method of monitoring labor and more intensive, more appropriate. But as and when it is implemented in the hospitals, we'll teach you more in detail. Now, they've specially asked you about the labor care guide, and that's why we should know that labor care guide says that why put the patient on the delivery table at 4 centimeters? Let's wait at 5 centimeters. So WHO says now that active stage of labor is 5 centimeters. So if they ask you according to labor care guide, what is the active stage of labor? Say 5 centimeters. Right now in all your partograms, all your interns, when you were working in the labor room, those who are currently working in the labor room, go and see the partograms. They're all starting at 4 centimeters. But they ask you labor care guide specially, which I'm very happy that UPSC has written that. Labor care guide, according to that, it is 5 centimeters. If they ask you American College of Obs and Gynae, then this 6 centimeters and more is the active stage of labor. So I'm very happy that they asked you a specific question. Now that's what is the benefit of having the exam questions in your hand. At least you know what they're asking you, so you answer appropriately, because you are all reading, but when you recall the questions and when we give you the answers, a lot of confusion happens, because if you're recalling, you will tend to do some mistakes in the recall. So good. Labor care guide says active phase of labor starts at 5 centimeters cervical dilatation. Correct. That's a correct statement. There's a fixed rate of dilatation of every hour of labor in active phase. Look, I expect that in the active phase, there should be 1 centimeter dilatation every hour. But yes, it can be more in a case of multigravida. It can be 1.5 centimeters or even 2 centimeters per hour in a case of multigravida. So that's why there is no fixed dilatation. So I'm not convinced with this. This is wrong. There is no alert or action lines in the partogram. That is correct. In the labor care guide, there is no such action lines or the alert lines. And there's a separate section of intensive monitoring for second stage of labor. Correct. There's a separate section in the labor care guide. So we say choice 1, 3 and 4 is correct. So 1, 3 and 4 is choice B here. So for the purpose of answering this question, this is the answer. Now let me just quickly show you the labor care guide. Now labor care guide has 7 sections. So if you see the sections, the section 1, that is the time when the patient came in, and the 12 hours of the active phase of labor, which is after 5 centimeters. Generally the labor should finish in 12 hours. This should not be more than 12 hours. That's why the labor care guide is also showing 12 hours. And then the next thing is that this is the active first stage, and after that they've given you the separate. Can you see this line? There's a separate second stage of labor section also here. So along with this, along with the data when the patient has come in, the name and all, the next section is the supportive care, whether there's a companion with the patient or not, pain relief she's taking or not, oral fluid she's taking, and the posture, whether she's in supine or she's sitting, and then the baby's details. What is the basal fetal heart rate and whether there is deceleration or not, amniotic fluid, fetal position, cap put and molding. Almost the same things which are there in the previous partogram, but there's a different method of depiction. So after this, the next section is the woman, the mother's parameters, the pulse of the mother, the diastolic and the systolic blood pressure, temperature, urine. Then the labor progress. There is the contractions, duration of contractions like we have, and then the cervix dilatation and the descent of the head. And then the medication section, when you're giving oxytocin, how much it is going, and the other drugs which you're giving in labor. After that, the next section is about the shared decision making. When you've done the assessment and your findings are written here, what are you planning and how the labor is continued, or you want to change your decision based on the findings to do a cesarean section. So that is the labor care guide. Remember, there is a separate section. I've separated it for you to understand. This is the labor care guide, the full chart together. Along with that, you'll see that there's a at the same level. It's just that I'm just showing you that there is a separate section for the second stage. All the same things seen in the second stage also. And that is generally they've given space for you for 3 hours, because the average second stage in a multigravida is 30 minutes and in a primary gravida it is 1 hour. So more than 2 hours is delayed in a case of a primary gravida and more than 1 hour is delayed in a case of a multigravida. That's why the maximum they've given 3 hours duration in the second stage of labor. That's the labor care guide. So along with that, so keeping all of that in mind, I've already given the answer that these 3 statements, statement 1, 3 and 4 are correct. So choice B is the answer for that question. Now, the next question is about the breech vaginal delivery, my favorite topic. Which of the following are the positive indicators for a breech vaginal delivery? So, when we say breech vaginal delivery, remember we do breech vaginal deliveries. It is not contraindicated to do breech vaginal delivery, and you will get questions on this if you are a final year MBBS student. You will get questions on this if you are writing PG entrance exam, and if you are a postgraduate, whichever medical college you are working, you will be taught breech vaginal deliveries. So, don't say primary breech, I will do cesarean section straight away. Yes, it is done like that in private practice. People want to play safe, but breech vaginal delivery is standard obstetrics. We have asked you about Pinard's maneuver and Loveseth's maneuver. We've asked you about Burn Marshall technique, and breech is taught and it is practiced and it is asked in the exams still very much. Okay, so don't think that breech you do cesarean and that's the end of all the discussions. Wrong. So, which are the following positive indicators of breech vaginal delivery? The fetal weight should be less than 1.5. So, that's a very small baby. So, if there is a breech with a weight of less than 1.5, that's a very small for date baby, and a small baby, a growth restricted baby, whatever reason it is for, it's a complicated breech. Complicated breech, we do cesarean sections. So, breech with a previous cesarean, it's a complicated breech, we do cesarean section. But if the weight is more than 1.5, then it's a baby which we can try for normal vaginal delivery. So, frank breech, that is the extended or frank breech. Extended breech is also known as the frank breech, where the body is completely having, the legs rather are extended. The arms are flexed obviously. So, extended breech is like this. The flexed breech is something like this. Both the legs are flexed. So, this is the most common breech and best for vaginal delivery, the extended breech. So, extended or frank breech, and the weight of more than 3.5. No, that is wrong. We should have less than 3.5. More than 3.5, some books say, in India we say more than 4 kgs is macrosomia. In West they say more than 4.5, but more than 3.5 we are also a little worried of doing a breech vaginal delivery. I know I've done once a baby who was 3.5 kgs. I've done a breech vaginal delivery, and that was questioned by so many of my seniors that you actually had a baby more than 3.5 kgs which you delivered vaginally. They checked the baby weight 3 times just to make sure that I was claiming a correct delivery which I had done in the night. So yes, more than 3.5 we will not do. So extended breech is correct, but not more than 3.5. Let's see the next question. Frank breech, which is extended, fetal weight 1.5 kg to 3 kg, gestation age more than 34 weeks. Yes, that seems to be the best answer in these 4 choices. Now, the next question is about puerperal pyrexia. Which of the following correctly defines puerperal pyrexia? Now, puerperal pyrexia, remember, is fever after delivery, but not immediately after delivery. Look, if a woman delivers at 7 p.m. and she has fever at 8 p.m., that's not a puerperal cause. It's probably because she had UTI before delivery itself, or maybe she had pneumonia. So, whatever fever comes immediately after delivery in the first 24 hours is probably because of a cause before she delivered. After 24 hours, the puerperal causes set in. So, that's why we say puerperal pyrexia is after 24 hours. And generally, these are genital tract. These are because of genital tract infections. Right. So, a rise in mental temperature of 100.4 degree Fahrenheit or more, 101.4 degree Fahrenheit or more, 24 hours apart within the first 10 days. So, 10 days is correct, but 101 is wrong. 100.4 degree Fahrenheit or more, which is 38 degree centigrade. You should remember this also. You know, this 100.4 is also the criteria for admission of a woman in the hospital when she has pelvic inflammatory disease. Also, the temperature, if it is more than this, after an abortion, to say that she's getting into sepsis, septic induced abortion also. So, this 100.4 degree Fahrenheit or 38 degree centigrade comes many times. Okay. So, the answer to this question is A, puerperal pyrexia. Then, a mother presents on day 8 of normal vaginal delivery with pain in the left breast with fever and chills. On examination, her left breast is tender and red with raised local temperature. What should be the line of management? Left breast is tender and red. with raised local temperature. She's obviously having mastitis. They're not talking about fluctuation, so that's why it's not looking like a breast abscess so far. It looks like a mastitis, which is a common problem which can happen if care is not taken of the breast. So what should you do in a case of mastitis? So mastitis, we say that you can give antibiotics, but make sure that you don't stop the breastfeeding. Generally, what we say that the affected breast, let's say the left breast in this patient, so left breast is affected, you tell the mother, take care of this left breast, give fermentation, hot fermentation will give a relief, and she can feed the baby from the right breast first. And that right breast, when it is emptied and the baby wants more milk, then the baby goes to the left breast. She can feed from the mastitis breast. And remember, it is not bad milk which is going to the baby. It is just that the nipple will be a little swollen and difficult for the baby to latch on and to initiate a let down. So that's why the baby is made to feed on the normal breast first and then come to the affected breast, so that the let down is already initiated in this breast also by the feeding on the right breast. So she can feed from the affected, the left breast in this case. She can do that. So remember, analgesics and antibiotics, plenty of fluids, breastfeeding continued from the right breast, and can take it from the left breast also. I have given you extra information. Restrict fluid nahi karna chahiye. Okay, earlier they used to say that there is engorgement and there is enlargement of the breast because of the swelling, and you should not give more fluid, it will cause fluid retention. All of that is very old teaching. So answer is already, the best one is already this. Let's not get into incision drainage already, because there's no abscess. We have not said there's an abscess right now. Okay, so let's see. Mastitis generally seen after 3 to 4 weeks. This case it is seen at 8 days, but generally seen around 3rd week of the delivery. And the symptoms and signs are pain, severe pain, chills and rigor, fever and tachycardia. Breast is often hard and red, and approximately 10% of women with mastitis will eventually develop an abscess. And most commonly this mastitis because of Staph aureus. So we must generally do a culture and give the appropriate antibiotics, but mostly giving penicillin group of drugs is a good treatment. Mostly we give, ampiclox or dicloxacillin, one of these drugs we give, and patient is fine. Nowadays we say that we can start the antibiotic by the time the culture results come. You can start giving them some relief. Yes, when the culture results come, it generally takes 3 days. So you don't have to wait for that long. You can give some penicillin group of drugs and the patient will be just fine. Now, consider the following abnormalities in a woman with preeclampsia. Platelet count is less than 1 lakh, serum creatinine is more than 1.1, pulmonary edema, proteinuria. Which of the following describes severity of preeclampsia? Now, we say severe preeclampsia when the patient's proteinuria is more than 2 grams in 24 hours, not 1 gram. Okay, and we say that the patient is having added signs like there is liver damage and the platelets are getting reduced. All of these will inform about the severity. So platelet count is less than 1 lakh, its severity definitely. Serum creatinine is 1.1 and pulmonary edema. I'll go with 1, 2 and 3. So the answer for this question is A. All right. Which of the following parameters precisely defines grade 3 abruptio placentae? Grade 3 is the worst type of abruption by the Sher-Page category of classification of abruption. And when we say worst type of abruption, it is generally associated with fetal death, may also be associated with DIC. All right, so moderate vaginal bleeding, maternal tachycardia, low fibrogen levels, and intrauterine fetal death. So this bleeding alone is not the criteria. This fetal death is a pathognomic feature. I mean to say that fetal death is invariably seen in the stage 3, the severe grade of abruption. All right, so these are the grades. Grade 1 is 150 ml of less. This is the Sher's classification. It is generally diagnosed only after the delivery. When we do the delivery and when we do the control cord traction of the placenta, behind the placenta you see a clot of, small clot. And then you realize that this patient had an abruption. Before that, she didn't have any symptoms. That's the safest type. And the worst is the grade 3, where there is, absent fetal heart rate and there is bleeding before the patient had delivered, and it may be associated with DIC also. So So that is what is the worst type of abortion which was asked in this question. So choice D is the answer for this one. A primary graduate comes to antenatal clinic for a routine antenatal visit. When should she be screened for diabetes in pregnancy? Now, I've been shouting hoarse teaching you this in all the sessions wherever I have met you, including in my PW app, and I'm telling you repeatedly that when a patient comes in the first trimester, we screen for the pre-gestational diabetes, because pre-gestational diabetes presenting in the first trimester will cause anomalies, because that's the organogenesis period. GDM doesn't cause anomalies because GDM starts after 24 weeks of gestation. The pregnancy, gestation diabetes mellitus, gestation की वजह से diabetes. So when something is wrong in the pregnancy, like high human plasma lactogen coming from the placenta, that is going to destroy the insulin, and there's going to be increased insulin resistance around 24 weeks and beyond. That's why the sugars increase in pregnancy after 24 weeks. So that's why when a woman who is pregnant and comes to me for the first time, let her be a primary gravida, I will suspect diabetes in the first, P team थोड़ा सा एडिट है, ये वाला सेगमेंट फिर से करते हैं. When a woman comes to me pregnant, be it for the first time, वहां से फिर से बोलूंगा P team, ठीक है. So when a woman comes to me for a pregnancy, whether it is the first time or the second time, and she has no history of diabetes, she's never had diabetes, still in the first trimester I'll look for pre-gestation diabetes, because if the sugars are high, there can be anomalies. So first trimester I screen for pre-gestation diabetes, and if there is no diabetes in the first trimester, that means she's continuing the pregnancy, and around 24 weeks gestation diabetes can present. So we'll screen for gestation diabetes at 24 weeks of gestation. So yes, how do we screen in the first trimester? The first trimester screening is by the glycosylated hemoglobin, HbA1c. It should be less than 6.5%. All right. And the second trimester, we'll do the screening after 24 weeks. And that is by the 75 grams oral glucose tolerance test. All right, so at 24 to 28 weeks and repeat at 30. That's wrong. Early in pregnancy, repeat at 24 to 28 weeks of pregnancy. This looks like the answer. Early in pregnancy, repeat 32, wrong. 9 to 11 is, and 32. This is wrong. So answer is B for Bombay. Early in pregnancy, that is when she comes to me for the first time, glycosylated hemoglobin, and after 24 weeks, we do the 75 grams glucose tolerance test, and the fasting should be less than 92. I'll write that for you. GTT is a one-step test. So fasting should be less than 92, less than, not less than, equal to. Then you give 75 grams of glucose, and then 1 hour level should be less than 180, and 2 hour level should be less than 153. And if even one value is abnormal, then we say the patient has GDM. That's why it is a one-step test. Now this is what is coming in all the exams and all the previous tests. I'm not saying they are redundant, but they are never asked, because what is practically done in all the hospitals is this one. There are some DIPSI guidelines, there are some other guidelines of National Institute of Health guidelines, but these are the American Diabetic Association recommendations, and they were accepted, and this is what is done in all the hospitals now. This is what is coming in your AIIMS exams also. It has come when it was AIIMS, then it became the INICT. It's been coming with the same values. Please remember this one. Next question, a primary carer comes to the obstetrical clinic at 6 weeks of pregnancy and mentioned that she's a known case of epilepsy and is taking anti-epileptic drugs, valproic, since 2 years. What will be your next step regarding her medication? Now, when we're talking about this, remember, anti-epileptics, if a patient is taking, she should always plan a pregnancy in consultation with a neurologist and the obstetrician. She should stop them ideally 3 months before the pregnancy is planned, or at least 1 month. So 1 month before, at least she should stop and change to a safer drug like levetiracetam or lamotrigine. So lamotrigine and levetiracetam, both are the drug of choice, and here they're talking about levetiracetam. I think that's a good drug to give in pregnancy. But if the woman is taking these anti-epileptic medications like valproic acid or phenytoin and she gets pregnant, there's no point stopping them. 6 weeks, 7 weeks, the pregnancy is already gone. The level of the drugs is at peak. And now she's gotten pregnant without her knowledge. She comes to you and says, sir, I missed my period and I didn't come to you in time. My pregnancy test is positive. How pregnant are you? I'm 6 weeks. So 4 to 8 weeks, the organism is already started. So the valproic acid has already got its effect done. And it takes, the 5 half-lives, which will be at least 6-7 days for the complete washout to happen of this drug. So that will be 7th week by the time the valproic acid will be totally washed out. So the effects of this drug has already been done. So there's no point stopping this drug and changing. That's what is classical teaching. But I think the questions might be answered by January and you'll get the right answer, what the UPSC expects. Right now, there are some guess answers which have been given, and they say that you should stop valproate and start levetiracetam. I would want to say that stopping the valproic acid is not going to change anything for the baby. And if you do a search on the all the articles on the internet by a ChatGPT or even by Gemini, you will get to know very easily that the world over the opinion is that continue valproate and increase the dose to explain the risk of teratogenicity. Now, continuing valproate is fine, but increasing the dose also is a little controversial. So, continuing valproate, explaining that the current dose, whatever she is taking, can increase the risk of teratogenicity. That is the best thing I'll say. But increasing the dose, now again, that's a problem. So, there are 2 possible answers. A is correct. B is what the UPSC website is giving as the answer, but I don't agree with B. The final answers will come in January 2027. Till then, we are waiting. But the best answer right now is to continue valproate because the effect has already been established in the baby. The baby, if at all, has to have the teratogenicity, it is already done. Too late for you to change the drug. So, this question has classically come with phenytoin. You continue the phenytoin. If the patient is already pregnant, there is no point changing because the effect is already gone. With valproic acid also, it is too late for you to change. Okay, but increasing the dose, I am not too happy. Best answer for the current choice given to me is A. All right, let's move on and see something else. Now, the next question is on Rh-isoimmunization. Next step to follow for a mother with Rh negative pregnancy and antibody titer above critical level when the husband is Rh positive. What would be the next step? So, mother is Rh negative, father is Rh positive. Let's say mother is A negative and the father is A positive. So, the positive means the Rh antigen or the D antigen. Rh antigen same as D antigen. Mostly nowadays we say D antigen. So, if the mother gets to be contaminated by the D antigen during pregnancy itself, she is pregnant and the D antigen has come in because there was a small injury on the tummy. Somebody, she was closing the door and the door hit her on the abdomen and some transplacental bleed has happened. So, the D antigen or the Rh antigen has gone into the mother. Mother has recognized the D antigen and she is making antibodies to the D antigen. So, when the D antigen came to the mother, mother started making the anti-D antibodies. Those anti-D antibodies will destroy this fetal blood which has come into her circulation. But now she is filled up with the anti-D antibodies. These antibodies will go from the placenta to the fetus and start doing hemolysis of the baby. And the baby can have hydros fetalis and can even die. So, what is your management? So, when the baby is exposed to anti-D, there can be hemolysis. There can be hemolysis, but don't get immediately very alarmed when a mother is having a antibody test positive in pregnancy. There are many steps before we get scared. Mother negative, father positive. Do the indirect Coombs test. Indirect Coombs test is positive because there is a antibody titers above the critical level. So, what are the steps? We'll see that first. Then we'll understand this much better. So, let's say IC is positive. That means the mother is exposed to the D antigen. She is making anti-D antibodies. Check how many antibodies are there. So, what do we do next? Check the titer of the antibodies. 1 ml of the mother's blood you take and that blood comes positive for the antibodies. Okay, it's positive. Dilute it to 2 ml. and see, it is negative. How? Such less amount of antibodies that when I dilute the blood to 2 ml, the test is negative. That's a very low number of antibodies. So whenever the antibodies comes test positive, we keep diluting that blood and see how many dilution the test is coming positive. So ICD is positive, check the titer of the antibodies. Now the titer of the antibodies is less than 1 in 16 dilution. Matlab, you diluted 1 ml to 2, it is positive. 2 ml to 4, it is positive. 4 ml to 8 ml, it is still positive. 8 ml to 16, it is still positive. Doubling dilution, we say. Now, when I double 16, that is, I make it 1 in 32 dilution, it is negative. That means in 1 in 32 it is negative, but 1 in 16 it is positive. If it is positive till 1 in 16, it is supposed to be safe dilution, safe titer. So check the titer of the antibodies. If the titer is positive in 1 in 16, but after that it is negative, that means it is the safe amount of antibodies, and that antibodies are going to the baby. They're causing some hemolysis, but the baby is also making blood in the bone marrow and the liver and the spleen. So this amount of antibodies are causing some amount of hemolysis in the baby, but it's not significant amount. Continue the pregnancy. So that's what we do. This is safe titer, continue the pregnancy, and continue doing the ICT on a monthly basis. Now what happens? The question which has come to you, it is beyond the critical level. So ICT level is more than 1 in 16. If it is more than 1 in 16, that means hemolysis is going to be significant. So check the amount of hemolysis. How we can check the hemolysis? We can check the hemolysis in the fetus by seeing the bilirubin levels in the amniotic fluid. So we can do amniocentesis, and this amniocentesis is subject to a spectrometric analysis, and that will tell me how much of bilirubin is there, because if there is more bilirubin, there will be more optical density, and more optical density means there is more hemolysis. Now this is invasive. You are putting a needle into the mother's abdomen, going to the amniotic fluid and aspirating. Amniocentesis itself can cause complications, infections, and even fetal death sometimes. So yes, this is invasive and we don't do this anymore. What do we do these days? We check the peak systolic velocity of the middle cerebral artery, MCA, middle cerebral artery of the baby. So the middle cerebral artery, we do an ultrasound of the mother. Through the ultrasound, we reach the baby's head, and in the baby's head, we see the middle cerebral artery and see the peak systolic velocity. If the baby is having too much of hemolysis, obviously his cardiac output has to compensate for the hemolysis. So he'll be contracting his heart too much and will increase the flow all over the body, and especially to the brain. There is a brain sparing effect. So brain gets a lot of blood when the baby progressively gets anemia. So if the titer is very significant, that is more than 1 in 16 dilution, then we do the middle cerebral artery velocity, the peak systolic velocity of the MCA. Now, middle cerebral artery velocity will increase with progressive anemia. So, if the peak systolic velocity is more than the normal for that gestation, then it is significant hemolysis. So, if it is more than 1.5 of the median, multiples of median, MOM units, multiples of median. Look, suppose we are doing this test at 28 weeks or 32 weeks, whatever. So when we are doing this, every gestation will have a normal peak systolic velocity. Now, if this baby's peak systolic velocity is more than 1.5 times, that means from the median of that day, it is more than 1.5 times. That means multiples of median, more than 1.5 times of the median value. That means it is too much of hemolysis and that baby is going to die. So what is significant? That's what is the question asked. If it is significant hemolysis, then what do we do? If it is significant hemolysis, then we should think in terms of either termination or giving blood. So depending on the gestation. So if the gestation is more than 34 weeks, then I will deliver. But yes, if the gestation is 28 to 34 weeks, then I can think in terms of giving intrauterine transfusions. I'll give steroid for the acceleration of the lung maturity, and I will give some intrauterine transfusions to gain some time. So, hemolysis happening, I can put a needle under ultrasound guidance, reach to the umbilical vein of the baby and give intrauterine transfusion according to the weight of the baby it is calculated, and that will buy time. Hemolysis treated by blood transfusion. Anybody having hemolysis, we give them blood transfusion. So, babies having hemolytic anemia, give blood transfusion and buy some time for the lungs to get matured and take a decision. So, 28 to 24 weeks, it becomes a very difficult decision to take, but at least we can give blood transfusion, buy time for the maturity of the lung, and then decide when we can deliver. After 34 weeks, the lung is mature, you can deliver and give the exchange transfusions, which the neonatologists do it very frequently. So, that's the management. Okay. So, the answer to this question is obviously the middle cerebral artery peak systolic velocity. Now, the next question is about the growth restriction. Early onset fetal growth restriction is diagnosed. See, the growth chart when we make, whether you see the bipedal diameter or the abdominal circumference of the femur length, we have a growth chart. So, we'll have what is the normal expected growth of the, let's say, of the femur length if you are checking, and this will be the 90th centile and this will be the 10th centile. So, 50th, 90th and the 10th. These are the centiles by which we are expecting the growth. Now, if the growth of the baby in gestation in weeks, if the growth of the baby is coming less than the 10th centile, suppose the growth is coming till here. If it is less than 10th centile, we say it is small for gestational age, small for dates. Now, that can be a constitutionally small baby. A constitutionally small baby because maybe both the parents are small height and the baby is also going to be small, or it could be fetal growth restriction or intrauterine growth restriction, like they say. And if it is less than the 5th centile, some pediatricians say less than 3rd centile, that is known as severe IUGR. But for diagnosis of small for gestational age is less than 10th centile, which can be constitutional or growth restriction. Now, if this happens before 32 weeks of gestation, then we say it is a early onset fetal growth restriction. So, before 32 weeks and after 32 weeks is generally we say, but before 32 weeks is a more early cause, means it will be a more severe cause. It could be more genetic causes, and late onset is like things like PIH. So, those have a better prognosis. Early onset have a worse prognosis. Right. Consider the following statement regarding vaginal epithelium in adult females. So, vaginal epithelium is not clinical question. Like I said in the beginning, they will ask you a lot of anatomy and a lot of histology and physiology in a UPSC exam along with the clinical questions. So, it's a good question which they've asked, that regarding the vaginal epithelium. From puberty till menopause, the vaginal epithelium is devoid of any glands. Yes, vagina does not have any glands, which is a correct statement. Basal epithelium of the vagina contains the glycogen. Look, glycogen is the carbohydrate in the vagina and the cervix. Yes, we've discussed this even in the case of when we're doing the Schiller's iodine or the Lugol's iodine for the colposcopy to see abnormal lesions. And when we put this iodine, the glycogen rich cells will take the iodine, and the areas which are rapidly dividing will eat up the glycogen, they will stay colorless. So, all that knowledge about glycogen is used for the diagnosis of CA cervix also, or the colposcopy in cervix. So, that knowledge is based on this information, that glycogen is the carbohydrate in the vagina. But is it in the basal layer? That is a wrong statement. It is in the intermediate layer. So, intermediate and superficial layers become continuous with those covering the vaginal portion of the cervix. Correct. The cervix also has the 4 layers just like the vagina. So, that's a correct statement. And unlike skin, this vaginal epithelium does not have hair follicle. This is also correct statement. So, the answer to this question is A. Right. So let's read about this a little bit. That the basal layer, the stratum basal of the vagina, is a single layer of columnar or cuboidal stem cells resting on the basement membrane. The parabasal layer is the stratum spinosum prickle cell layer, and the intermediate layer, the stratum granulosum. These are the ones which progressively accumulate large amount of glycogen. So intermediate layer is the correct answer. So the question I've already answered for you. The basal layer doesn't have the glycogen, the intermediate layer has. And superficial layer is known as the stratum corneum, the topmost layer consisting of large, flat, mature squamous cells. Okay, right. Now, the intermediate layer, like I told you, is the thickest layer of the epithelium, thickest zone, and under the influence of estrogen, the cells in the layer synthesize and accumulate large amount of glycogen. Which of the following statements is true regarding the neurovascular anatomy of the uterus? So that's also one question which keeps coming about the blood supply, the internal iliac artery question. So the uterine artery arises from the antedivision of the external iliac artery. That is wrong. It comes from the internal iliac artery. Uterine artery crosses 3 to 5 centimeters lateral to the internal os. Wrong. It is around 1 to 2 centimeters lateral to the internal os. The venous channels of the uterus drains in the internal iliac veins, which is correct. The somatic distribution of the uterine pain is the area of the abdomen supplied by T5 and T6. It is a little higher, T4. Okay. So the answer to this question is C. The venous channels drain into the internal iliac veins, because the internal iliac artery is the arterial supply, the division of the antidivision, and that's what is supplying the uterus. So the veins also follow the same route. They go to the internal iliac veins. So the question here is about the veins, but I'm just giving you the picture of the common iliac. Here the common iliac is dividing into external iliac here and the internal iliac here. Internal iliac has the antedivision and the posterior division. Posterior division has only 3 branches: the superior gluteal, the iliolumbar, and the lateral sacral. Short gills, small gills. Fishes have short gills, or you can say Shubman gills. It's a good mnemonic to remember: superior gluteal, iliolumbar, lateral sacral. And the antedivision has all the major branches, including the uterine artery. So the uterine artery is from the antedivision of the internal iliac artery. So the vein is also correspondingly the internal iliac vein. All right. So answer I've already given to you. The answer is the venous channels of the uterus drain into the internal iliac veins. All right. Let's see the next question. When does the secondary oocyte complete the second meiotic division? Now, after asking you some physiology, then some anatomy, now they're asking you some embryology also. So the secondary oocyte, remember, the oocyte, when the girl is born, the oocyte is the primary oocyte and it is resting in the prophase of the first meiotic division, and then it resumes at the time of ovulation when the girl gets into the pubertal age. So just showing you in a diagram. So the oocyte, the primary oocyte, is arrested in the prophase of the first meiotic division, and then when the secondary oocyte is made, when it is resumed at the time of ovulation, there is a release of the first polar body. That is what is the secondary oocyte now, when the release of the first polar body happens. Now, when does this first polar body get released? It releases at the time of ovulation. So that's why this is what is the secondary, the second meiosis which is happening, and this is what is called a metaphase 2, metaphase 2 oocyte, when it is released at the time of ovulation. So just before ovulation, the first polar body is released. So just before ovulation, A is the answer. Now, why am I sure about this one? As it is, because this is what I do for IVF. When the oocytes, when I retrieve from a woman who is getting ready for an IVF process, the oocytes are the metaphase 2 oocytes, the one which is ready for me to use the husband's sperm and fertilize these oocytes is the M2 or the metaphase 2 oocytes, because the polar body is released. So yes, that's when I know that the egg which I'm getting is ready now, and it is at the time of ovulation or just before. It's not 24 hours before. A lot of students keep saying so it is 24 hours before ovulation, the release of the first polar body. No, it is just before or at the time of ovulation, and that's why we get mature oocytes at that time. If it is happening 24 hours before ovulation, then I'll be too late for using those eggs for causing a artificial fertilization. Okay, so please remember, just before ovulation is the right answer, and I've given you the pictures here. Now this metaphase 2 oocyte is having one polar body. Now when the sperms enter this oocyte, then the second polar body is also released. So the first polar body is at the time of ovulation, and the second polar body is released after fertilization. Right, the growth and differentiation of the primordial follicles, more histology and anatomy, is under the control of which hormone? So growth, follicular stimulating hormone, is responsible for the growth of the follicle. The high FSH in the initial few days of the menstrual cycle, like this, then mid-cycle peak and high again at the end of the month. This high FSH in the initial, that is the if you say 0 to 20 day of the menstrual cycle, the high FSH will recruit 6 or 7 antral follicles. Now the low FSH will be enough to maintain growth of one of these follicles, and that will become the dominant follicle with a oocyte in it, and that will be around 15 to 20 millimeters when it is mature to ovulate. So high FSH will recruit follicles, low FSH will maintain growth of one of these follicles, that is the smartest follicle, which can use the low FSH to start growing. So this FSH is responsible for the growth and differentiation. So we will not be worried about this one. That's a straightforward question. Consider the following statements with respect to endometrial cycle. Now first question was about the vaginal epithelium. Now this is about the endometrium, the lining of the uterus. Okay, now lining of the uterus has 3 layers. The basal zone is uninfluenced by any hormone. Correct, this is a correct line. This is unaffected by any hormone. Sawtooth glandular epithelium is seen in the secretory phase. That is also correct. And stratum compactum contains mainly the glands and less stroma. Now you must understand the layers, and then you will get a better understanding. So the 3 layers of endometrium, the stratum compactum is the superficial layer. So that's why you must understand this, that the superficial layer of the stratum compactum, the topmost layer, it consists of the stroma. The superficial layer is the stroma and the neck of the uterine glands, not the body of the uterine glands. That's what is the question here. So the question here is, stratum compactum contains mainly the glands. No, it is the next layer which contains the glands, the stratum spongiosum, the middle layer. This is the spongy layer characterized by the edematous stroma, not the major amount of stroma, and the tortuous body secretion of the uterine glands. All right, so the answer to this question is B, right? That the basal zone is uninfluenced by any hormone. Correct. Sawtooth glandular epithelium is seen in the secretory phase. Correct. And the stratum compactum, no, it is the stratum spongiosum, the middle layer, which has the glands. And pseudo stratification seen in proliferative phase of the menstrual cycle, that is also correct. So these 3 statements 1, 2 and 4 are correct, and that is in choice B of this one. Okay, so quickly we'll see what I told you. Stratum compactum is the superficial layer, has the stromal cells. Stratum spongiosum has the body of the uterine glands, and stratum basal, the deep basal layer, the deepest layer adjacent to the myometrium, contains the blind ends of the uterine glands and does not shed during menstruation. It is unresponsive to the hormones like progesterone. All right, you must understand this one. Please rewind and listen to these 2 questions, the one about the vaginal epithelium and then about the endometrial epithelium and the characteristics. Right, which of the following statements explains self-priming or the auto-priming of the gonadotropes? So the gonadotropes, okay, which respond to gonadotropins. Gonadotropin releasing hormone releases the gonadotropins, that is FSH and LH are the hormones which act on the gonads. So LH and FSH are known as gonadotropins, and these gonadotropins are released by the gonadotropes. So how does this work? So the hypothalamus acts on the pituitary to release the gonadotropins, which are the FSH and the LH. Now that is in a pulsatile fashion. That's in a pulsatile fashion. So what is true regarding this auto priming or the self priming of the gonadotropes? So the lower GnRH pulse, okay, let me read this one by one. The lower GnRH pulse favors FSH secretion and high frequency favors LH secretion. Lower GnRH pulse frequency LH and higher frequency favors FSH. Actually, the answer is between these two. Let's see the second one. Lower GnRH pulse favors LH and FSH both. High GnRH pulse favors LH and FSH both. So these are just fill-in choices. These are the choices which are given just to fill in the 4 choices. So these two are not of discussion. So classically, we should remember in the follicular phase, the frequency is faster, amplitude is lower. In the luteal phase, the frequency is lesser, longer frequency. That means luteal, longer, okay, lesser frequency, but the amplitude is high. So if you see this is straight from Novak's Gynecology 16th edition, and you can see the pulsatile secretion of gonadotropin. I took the liberty of getting you the picture because there's a lot of controversy, because I think the website right now is giving a wrong answer, because it is faster in the follicular phase and longer in the luteal phase. That's how I've taught you in the app and any other place where you met me for the classes. So remember, faster, see, the frequency is much more faster in the follicular phase and longer. See, it is lesser, okay, lesser frequency. So faster in the follicular phase and longer in the luteal phase. That's the frequency. And if you see the amplitude, it is lesser amplitude in the follicular phase and more amplitude in the luteal phase. It is as simple as that. It is given in the book, and that's why I would go with lower pulse favor FSH, no, lower pulse favorite LH, and higher pulse favors FSH. So longer for luteal and faster for FSH. So I'll go with B as the answer for this question. It is contradictory to the answer given on the website, but yes, I'm waiting for January again for the best answer. I'm giving you proof from Novak's Gynecology, and I hope you will agree with what you see. Next question is on PID, students. Consider the following diagnostic criteria for acute PID diagnosis: lower abdominal tenderness, oral temperature more than 38 degrees centigrade, which is that 100.4 degree Fahrenheit, again, like I taught you earlier in the question about puerperal pyrexia also. So adnexal tenderness, cervical motion tenderness. Which of the following are included in the minimal criteria? The minimum criteria for diagnosis of PID. So when I say criteria for diagnosis of PID, I'll just tell you that, then we'll come to the answer here. Okay, so if you see the diagnostic criteria for PID, there might not be any symptoms present. Like chlamydia does not have any symptoms, it's an indolent PID. So symptoms of PID can be pain abdomen, she may come and say I have got excessive vaginal bleeding, she may have some discharge, or sometimes there might not be anything. So symptoms are not required to be seeing, but the signs are required, and signs generally are the clinical signs and symptoms like lower abdominal tenderness when I do the per abdomen examination, and when I do a per vaginal examination, touch the cervix and move it. So movement of the cervix will move the uterus also, if you can see, and if the uterus is inflamed, there will be pain. So cervical motion tenderness, adnexal tenderness. So these are the criteria for the diagnosis. So this is the minimum criteria: pelvic organ tenderness, which is uterine, adnexal or cervical motion, and leukorrhea and mucopurulent endocervicitis. So this is what they're asking you there. So that is the answer to this question. Minimal criteria is lower abdominal tenderness, adnexal tenderness, and cervical motion tenderness 1, 3, and 4. Because fever comes in the additional criteria. So 1, 3, and 4 is choice C. Now, if you say fever comes in the additional criteria, that is more than 100.4 degree Fahrenheit is actually a criteria for admission. It comes in the additional criteria along with endometrial biopsy showing endometritis, especially the chlamydia and the gonorrhea, and increased C-reactive protein. Now, what is the definitive criteria or the extended criteria which some books say? So this definitive criteria is the visual and the biopsy evidence. So ultrasound documenting a tuber abscess and laparoscopy showing a salpingitis. So if I see on a laparoscopy that the tubes and the ovary are inflamed and there is some mucopollen discharge coming from the fallopian tube sometimes, so that is the best diagnosis of PID. That's not what is asked in this question, but this has come many times in exam. What is the best diagnosis of PID? That is the laparoscopic evidence of inflammation of the fallopian tube. All right, so let's see the next question. Which of the following statement is true regarding genital tuberculosis? Now, most common site of affection is the ovary. No, actually, the most common is the fallopian tube. That is 100%. If there is the involvement of the pelvis with tubercular PID, the first organ affected always is the fallopian tube. 50 to 60% is the uterus, and then it is the ovary. That is around 10 to 15%, and vagina and cervix is the rarest. Okay, 5% chance. So the ovary is not the commonest. The ovary is much lesser than even the uterus. So tube always, uterus many a times. Okay, ovary, vagina and cervix is rare. So this is wrong. Which is true, they are asking. So this is wrong. Abdominal ostium is closed and it may be open also when there is a tubercular hydrosalpinx. Doesn't mean that the ostium will always be closed. So that is wrong. Most common mode of spread from primary to genital organs is the hematogenous. Yes, hematogenous spread from a primary focus in the lung to the uterus. That is the most common spread of tuberculosis to the uterus. This is the answer to this question. What is the fourth one? Genital tuberculosis occurs in 1 to 2% who had pulmonary tuberculosis in adolescence. So if a girl had pulmonary tuberculosis, what is the chance that she'll have genital tuberculosis? That is not as low as 1 to 2%. It is 5 to 13% or 5 to 10%, some books will say. Okay, so it's a much higher percentage rather than just 1 to 2%. So that is also a wrong statement. Answer is C. The drug of choice of treatment of chlamydia. Chlamydia, we say the kit 6, and kit 6 has doxycycline. So doxycycline is a good drug, but the drug of choice is always azithromycin. That's a straightforward question. Not waste much time in that. I'll just tell you these are the 6 kits, and the kit 6 which we keep giving in the the syndromic approach, it has cefixime, metrogyl and doxycycline. So that is there in the kit. But yes, even better than doxycycline is the azithromycin. So azithromycin is even better because it can be given if you're suspecting chlamydia during pregnancy. So azithromycin safe even there. But the kit 6 has this doxycycline. Answer I've already given to you is azithromycin. Next, see the next question. Kit used in syndromic. Same question again. Kit used in syndromic management of STI include which one of the following combinations? So when we are suspecting reproductive tract infections, then we think of cefixime, metrogyl and doxycycline. That is the answer. Question is related to the previous question here. So I've already shown you the kit. Let's move on and see next question. The most common site of vulval cancer is the parts of the vulva. If you remember, vulva is labia majora, labia minora and clitoris. That is vulva. The whole external genitalia is not called vulva. Labia majora, minora and the clitoris. So this is the part of the introduction to most of my classes, and look, a question has come on that. The most common site is obviously the labia majora. All right, 15% it can be in the clitoris also. So 60 to 65% cases it's there, and 15% it can be the clitoris, but most common is the labia majora. All right, this one here. Now let's see the next question. This is about the treatment of cervix by radiotherapy. Point A in radiotherapy in carcinoma cervix marks the site for which of the following structures? So we have to give radiation to control the cancer cervix. Immediately in the vicinity of the cervix, we have to give more radiation, and a little further, we have to give radiation a little lesser to control the disease spread. So let me try and explain that to you with the diagram here. Now, there's the uterus, cervix in the vagina, and suppose there's the pelvic side wall. You see that the ureter is coming lateral to medial in the pelvis, and the uterine artery is above that. So we remember that the the relation of the ureter with the uterine artery is that there is a bridge over water. So the water is the urine which is coming in the ureter, and the uterine artery is the bridge. Now, what is point A and what is point B? So point A, it corresponds to the area which is 2 centimeters lateral and 2 centimeters above. this is 2 and this is 2. So that is point A. Point A is the place where the ureter is crossing the uterine artery. So this is the parametrium, and 3 centimeters lateral to point A is the point B. Now this corresponds to the obturator nodes and the extrailiac and the interiliac group of lymph nodes. So point A is where the ureter crosses the uterine artery, and point B is the place where you have the obturator nodes and the external iliac group of lymph nodes, the central group of lymph nodes for the cervix. So point A, suppose the cancer of the cervix is here. So point A, you're giving the tandems and the ovoids here to control the disease by radiotherapy, and then point A is bombarded by radiation to immediately reduce the disease in the parametrium, and point B is the place where you want to reduce the disease in the lymph nodes. So point A gets something like 8,000 rads, and point B gets something like 6,000 rads of radiation. So that is the reason why we have this point A and point B in the radiotherapy for the cancer cervix. So answer to this question is point A in radiotherapy in cervix corresponds to the place where the ureter is crossing under the uterine artery. Right, let's see the next question. Which of the following states the diagnostic criteria for post-molar gestation trophoblastic neoplasia? Look, when we do the evacuation of the molar pregnancy, a molar pregnancy should be evacuated by suction evacuation only. After that, we want the HCG levels to reduce. Now, if the HCG levels don't reduce, then we are suspecting that there could be a choriocarcinoma, which is one of the types of the gestation trophoblastic neoplasms. So, how do you know that is happening? So, the HCG should keep on reducing. One is that the HCG doesn't reduce, it keeps increasing, or the HCG is staying within plus minus 10% of the previous week's value, or it is persisting for more than 6 months. These are the basic 3 criteria. So let me show that to you in statements. So the HCG levels rise, it keeps rising, sequentially it keeps rising by 10%, more than 10% across at least 3 consecutive weekly values. That is, if you do it like first week, then the 7 days after that, and then 14 days after that, that is 3 values. For 3 values over 2 weeks time, it is persistently increasing. That is known as a post-molar GTN. Then HCG plateau, that it is within plus minus 10% of the value. Suppose it was 10,000. Now it is maybe around 11,000, or it has come down to 9,000, but it is not significantly increasing, but not significantly reducing also. So if it is plateauing, then also it is a criteria. And then there is another criteria, which is HCG persistence, that it is staying longer than 6 months detected, although it's not increasing or it is plateauing, but it is still detectable for more than 6 months. That is also one of the criteria. So which one of these criteria was there in this patient? A rise of HCG levels more than 10% for 3 values? No, that is a rise, correct. A rise of HCG levels of more than 5%? That is not correct. HCG rise of more than 15%? That is not correct. HCG rise of 10% for 3 values over 4 weeks time. So this is almost like this, but we have to say 3 values over 2 weeks time. So A is the answer. Let me show that to you here. See, 3 values over a 2-week time. So it's a little difficult to remember these values, but this is exactly how they are asking in the exams, and UPSC exam is based on a lot of clinical values, and this you have to remember that 3 values over a 2 weeks time. That is, today if you see, that is day 1, then 7 days later, and then 14 days later. So that is today's value, 1 week value, and 2 weeks later value. So there are 3 values. So 3 values over 2 weeks time. So that is the only choice which was matching the criteria which I taught you. Right. So A was the answer to that question. Now the next question is about uterine prolapse management for a woman who wants to save a uterus. Look, if a woman is having prolapse, mostly the woman is beyond 50 years of age and the treatment is hysterectomy. But sometimes there are women who are, let's say, around 28, 29 years of age who had one delivery and it was so badly done that she has a prolapse even when she is a very young lady. She had such a bad management that the ligaments got so weak that she has prolapsed in a young age itself. So suppose there's a woman who's 30 years, she has a prolapse but has only one baby. She wants to have more children. So we conserve this uterus by the Manchester surgery, also known as the Fothergill's surgery. So what are the steps of the Fothergill surgery? That's what they're asking in this question. Consider the following regarding the steps in Fothergill repair surgery for uterine prolapse. So out of these four steps, which of the above steps form a part of Fothergill repair for uterine prolapse? So let me tell you the steps of this, then we'll come to the answer, because see, just telling you the answer you will not be able to understand too much. So look, I'm trying to show you a lady who is having a prolapse. So what is a hysterectomy? We just we can just snip off this area here, and this uterus, if we take out, that is a hysterectomy. Of course, it's not as easy as I've shown. You have to do a lot of reflection of the bladder and the the rectum behind, and then isolate the uterus and do the surgery. Quite complicated because the anatomy is actually inverted totally. So hysterectomy for older women, but when you want to keep the uterus intact, so the ligaments which are so loose, so when you push the uterus back inside and tighten the ligaments so that it doesn't come out, that is what is the Fothergill surgery. So what are the steps of Fothergill surgery? So there are 5 steps of Fothergill surgery. First is the DNC. Now, why do you want to do a DNC? Because you're conserving a uterus. Suppose she is 35, 40 years of age and she wants to have more children. Now, at 35, if there is a atypia of the endometrium and you conserve the uterus, later she can have endometrial cancer. So, you will not conserve a uterus which has a endometrium which is hyperplastic and which is likely to have cancer. So first you do a DNC to make sure that the uterus which you're conserving is safe. Then there is cervical amputation, because invariably there is, after delivery, there is a compartment of there is a component rather of cervical elongation. So that cervical elongation, you have to do amputation of that cervix, and then you have to tighten the ligaments in front of the cervix. Which ligaments? The McInrod's ligaments, what is known as the Fothergill stitch. So this, let me show you the steps in a picture here. So you see the uterus is hanging out. So what you have to do, you have to push the uterus back inside, and to make sure that it stays inside, these ligaments, these McInrod's ligaments, they are removed from here and they are tightened in front of the uterus. So it looks something like this now. Both the ligaments are cut. The uterus, the ligaments are on the sides like this and the uterus hanging out. So push the uterus back inside and these ligaments you tighten in front of the uterus so that the uterus now is hanging by these ligaments, shortened, tightened ligaments, so that it doesn't prolapse out again. So these ligaments are obviously, they are coming from the pelvic side wall. So if you shorten and tighten them in front of the uterus won't come out again. So that is the Fothergill stitch, and then you have to, before that, do the cervical amputation also, because there is a component of cervical elongation in a case of prolapse. So those are the 3 steps, and invariably when a woman has prolapse, there will be some anterior compartment weakness and a posterior compartment weakness, which is the cystocele and the rectocele. So repair of the anterior vagina and the posterior vagina for the bladder prolapse and the rectal prolapse. So anterior vagina is known as the anterior colporrhaphy, anterior vagina repair is known as anterior colporrhaphy, and then there is a posterior colpopeneurrhaphy. So these are the 5 steps: DNC, cervical amputation, Fothergill stitch, anterior vaginal wall repair, and the posterior vaginal wall repair, which is anterior colporrhaphy and posterior colpopeneurrhaphy. These are the 5 steps of Fothergill surgery. So yes, what is the answer to this question then? The question is, what are the steps? Plication of McInrod's ligament in front of the cervix. Correct, that's what we do. Shortening of the uterosacral ligaments, that's not part of the surgery. Plication of the McInrod's ligaments behind the cervix, that is not done. In front of the cervix we do. And amputation of the cervix, that's what is done. So 1 and 4 is correct. So choice B is the answer to this question. Right. Consider the following surgical methods: Halcyons, Gilliam's, Spinelli's, and cutting of the anterior cervical ring. Now, Which of the methods given above may be used for the surgical management of a chronic uterine inversion? So the acute inversion, when you see the uterus inverts out in a case of delivery sometimes, mostly when an untrained person is removing a placenta and gives a very bad traction to the placenta, it can cause inversion to the uterus. So there what do? You have to push the uterus back inside, and that is the manual reposition which we mostly do. So that is acute inversion. Now when there is a chronic inversion, then what are you going to do? Then these are the surgeries. Now let me tell you these surgeries to make you understand a little better. I have given a picture here. So this is a line diagram of a uterus which is hanging out. The uterus is hanging out. It is inverted. It is not a prolapse. Uterus is inverted and gone out. So when the uterus inverted gone out, in an acute case, what do? You have just use your fist and push it back inside. But now this is a chronic prolapse. So what you can do? Sometimes you can do vaginal procedures or you can do abdomen procedures. Abdomen procedure, you can understand that I can cut the abdomen, go inside and apply two clamps on the uterus and pull the uterus back inside. So that is what is the abdominal approach to do the inversion repair. Or we can also do inversion repair by vaginal procedures. So let me show you one by one. So let's see the Holshin's procedure. Holshin's is one of the abdominal procedures where the cervical ring is incised posteriorly here and the uterus is pulled inside. Now the Huntington's procedure, this is also an abdominal procedure where the cervical ring is incised anteriorly and then Alice forceps is used to gently apply upward traction. So cervical ring is incised anteriorly and then you hold the uterus, pull it up inside by the Alice forceps. So that is the Huntington's procedure. So the cervical rings incised posteriorly is the Holshin's and the cervical ring incised anteriorly is the Huntington's, and Alice forceps were used to pull the uterus inside. And Spinelli's is the vaginal procedure which involves the replacement of the uterine fundus through anterior and posterior transection of the cervix. So anterior transection of the cervix and posterior, because the uterus has come out of the cervix, it is inverted. So if you cut the cervical bands, the uterus can be pushed inside easily. So anterior and posterior resection of the cervical band and then you push the uterus inside. That is the Spinelli's. So these are the three surgeries which I mentioned there. The only one which is not mentioned here in this list of the choices is the Gilliam's. So Holshin is the answer, Spinelli's is the answer, and cutting the cervical ring anteriorly. That is also what I have told you in the case of the Huntington's procedures. So all of these are the surgeries for inversion except Gilliam's. So 1, 3 and 4. So 1, 3 and 4 is choice C. That is the answer. And yes, you may not have read inversion surgeries in so much of detail, but yes, sometimes they'll ask you these kind of questions in UPSC. Now, when you are seeing these, remember Gilliam's operation is done for the purpose of a uterus suspension in the abdomen, a retroverted uterus which needs to be suspended to correct the retroversion. So the suspension of the uterus by shortening the round ligaments, that is what is the Gilliam's surgery. So that is not part of the inversion surgery. That's the answer to the question which I told you already. So Gilliam's is for the uterine suspension by shortening of the round ligaments, because if the uterus is retroverted, that can cause dragging pain also and also promote to infertility. So push the uterus anterior by shortening the ligaments. You know that the round ligament, is required to keep the uterus anteverted. So if the round ligaments are lax, then the uterus will be retroverted. So to correct the retroversion of the uterus and suspend the uterus anteriorly, so that is done by shortening the round ligaments, and that is the Gilliam's surgery. Now the next question is, in postpartum period, the intrauterine device may be inserted in the woman, that is the post-placental IUCD. The ideal time is within 10 minutes, but you can do it up to 48 hours. So 10 minutes to 48 hours is the time when you should do it. After 48 hours and the next 6 weeks if you do, you can cause a lot of infection. So post-placental IUCD can be given up to 48 hours of delivery. That's a simple one. Consider the following conditions in a woman of reproductive age: diabetes with retinopathy, age 36 years and a non-smoker, liver adenoma, history of stroke. Which of the following are absolute contraindications for the use of combined pills? So when I say combined pills, diabetes, controlled diabetes is not a contraindication. Uncontrolled diabetes is. Now this patient is having diabetes which is so uncontrolled that she is having retinopathy. So yes, this is a contraindication. Age 36 years, non-smoker. You can give COCPs up to 40 years of age to a woman. After that, we don't give. But if a woman is a smoker, especially more than 15 cigarettes a day, then at 35 years, we stop the COCPs, because COCPs with smoking both can increase the risk of coronary artery disease. That's why women after 40 stop OCPs, coronary artery disease can increase. Woman smoker, stop the COCP at 35 itself, because the COCP and the smoking both can contribute. So at 35 years in smoking women, we stop COCPs. So yes, this is not a problem because she is 36 years and a non-smoker. So that is not a problem. In this patient you can give. Liver adenoma you cannot give, and history of stroke you cannot give. So which of these are absolute contraindication? 1, 3 and 4. So choice C is your answer. 1, 3 and 4. Liver adenoma can happen because of COCP use, not hepatocellular cancer, please. Gallstones can happen but not gallbladder cancer. Liver adenoma can happen but not hepatocellular cancer with COCP. So this patient has liver adenoma, you cannot give, it's a contraindication. Which of the following statements regarding progesterone-only pills are correct? So they've asked COCPs, and the very next question is on progesterone-only pills. They contain high dose progesterone as there is no estrogen component. Now, progesterone-only pills are actually known as the mini pills. So mini pills is low dose, as the name suggests, low dose progesterone pills to achieve contraception. So this itself is a wrong statement. Select the answer using the code below, which are correct. So this is incorrect, this is not correct. They do not have on and off regime. They don't have a on and off regime. This is correct. What is the on and off regime? COCPs, when you're giving combined pills, they are on for 21 days and off for 7 days, isn't it? 7 days you're not giving the estrogen progesterone component, you're giving only the placebo, or you're giving iron tablets, isn't it, mostly? So on for 21 days, off for 7 days is COCP. So progesterone-only pills don't have this. Progesterone-only pills are given daily, and progesterone-only pills have to be given at the same time every day. That is, if she's taking at 10 o'clock today, then she has to take it 10 o'clock tomorrow morning. That's a problem with progesterone-only pills. In fact, you can delay it by maximum 3 hours. If it is more than 3 hours, then the effect is, is lost. So that's why same time every day, and if she misses more than 3 hours, then the concept effect is gone. So that's why combined pills are much better than progesterone-only pills to manage. So they do not have a on and off regime. Correct. This is a correct statement. They can be used with hepatic enzyme inducing drugs, not at all, because if you have hepatic enzyme induction, let's say by antiepileptics, so these progesterone components will be eaten up much faster by the body and the effectiveness will be lost. So you cannot give. The failure rate is 0.3 to 2%. Yes, that is correct. So choice 2 and 4 are correct. So I will mark 2 and 4 is A. Choice A is the answer to this question. So progesterone pills are called the mini pills. The progesterone dose is generally lower than the progesterone component of COCPs. COCPs have progesterone, but this is in progesterone pills even lower than that dose of progesterone in the COCPs. And hepatic enzyme inducers, all of you know this list, but I thought I'll anyway revise it for you. Antiepileptics like carbamazepine and phenytoin, phenobarbital, oxcarbazepine, then ATT like rifampicin and rifabutin, and antiretrovirals like efavirenz, nevirapine and ritonavir boosted regimes. Now, after undergoing vasectomy, how many ejaculations and months are required for a man to become sterile? Now, wherever I have taught you, I have always said that Williams Obstetrics says 20 ejaculations and PSM book says 30 ejaculations. After a vasectomy, it takes for the distal part to get emptied. After the part of the vas distal from the block, it will take 30 ejaculations or 20 ejaculations to empty. Now, I have always told you that it will be unfair if they give you both the choices, and now they have asked you that unfair question, that whether it is 30 ejaculates in 2 months, that is wrong. 20 ejaculates in 2 months. 2 months, though, anyway, we are not discussing. 3 months we are discussing. 20 ejaculates in 3 months is what is given by Williams obstetrics, and 30 ejaculates in 3 months is given by preventive medicine book. So I've always said that I'll have to go by the international reference, and Williams obstetrics is the, the considered as the Bible for obstetrics. Any doubts if you have, then Williams is the ultimate Bible for the last resort of solving your doubts. So we always teach you in the classes, even in the app I've taught you, that 20 ejaculates in 3 months is the answer. And on the UPSC website also they've given the same answer. Although there are a couple of answers which we discussed earlier, I don't agree, but they have chosen this one because the Williams obstetrics will carry a slightly more weight than the other books because it's an obstetrics books, isn't it? That's why. So yes, that's the answer to this question. It'll take, suppose you have given a block here, then this part which is distal, this part which is distal to the block, this will take, yes, this part, this will take 20 ejaculates or 3 months, 20 ejaculates or 3 months to get emptied. Right. Which of the following statements regarding lactation amenorrhea method are correct? It is equally effective in amenorrheic as well as menstruating women. Now, this is where it is wrong. The lactation amenorrhea is based on a constant, continuous breastfeeding of the child, and as long as the baby is frequently suckling on the breast, the prolactin stays high, and that high prolactin is going to inhibit the GnRH. So GnRH inhibition is required for the anovulation. Now, if she is menstruating, menstruation happens only if a woman is ovulating and she doesn't get pregnant, menstruation happens. So if a woman is menstruating and irregularly breastfeeding, definitely not be as effective as a woman who is breastfeeding and amenorrheic. So which of the statements are correct? This is a wrong statement. Risk of pregnancy in an amenorrheic woman who are exclusively breastfeeding, now that's what I was telling you, is less than 2% in the first 6 months. This is a correct statement. It requires exclusive breastfeeding for the first 6 months. Yes, she should exclusively breastfeed, don't give anything else to the baby, and very frequent breastfeeding is required to keep the prolactin levels high and suppress the GnRH. So if the mother is not breastfeeding very regularly, then there's a high chance that the prolactin will go low, and then the ovulation can happen, and that's why lactation amenorrhea is not a very good method of conception. You cannot tell a couple to rely on lactation amenorrhea as a method of conception, because most women cannot feed so regularly that they are constantly keeping the prolactin high to inhibit the ovulation. Many women who rely on lactation amenorrhea come to me after 7-8 months and say, sir, I'm not getting periods for 7-8 months because I've been breastfeeding. So what should I do for conception when I get my periods? So the next question is that you not got your periods for 7-8 months after delivery? Yes, sir, because I'm breastfeeding the child. Are you having intercourse? Yeah, we are having regular intercourse, but we are very sure because I'm breastfeeding, I'll not conceive. I do the pregnancy test, and so many times the pregnancy test is positive. Welcome to the ANC clinic again. It has happened many times. So yes, never tell a couple to rely on lactation amenorrhea as a very good method, because it is banking on constant breastfeeding, a much regular breastfeeding. Almost every 2 hours she should breastfeed. But if a woman is sleeping in the night, she'll breastfeed only probably once in the night, and that's the time when the prolactin levels will reduce and the woman can have an escape of gonadotropins and she can ovulate also. So that's why we say these two statements are correct. The failure rate for exclusively breastfeeding and menstruating women, see, exclusive breastfeeding and menstruating women, again contradictory statements. If she's exclusive breastfeeding, she'll actually not be menstruating, but this is 15 to 20%. So I don't agree, this will be much lesser, so that will be a wrong statement. So I feel that choice 2 and choice 3 are correct, so we'll go with answer B. So let me show that to you in a chart here, which is inspired by Williams obstetrics. So if you see in a woman who is postnatal, this is weeks after delivery. So the levels of prolactin, let's say 100 nanograms and 200 nanograms. So prolactin, every time the child breastfeeds, the prolactin will go high and then go low. and then the child breastfeeds, it goes high and goes low. So there is an episodic rise. So this question came in your NEET exam also, that what is the level of prolactin after delivery? In fact, it is lower than the pregnancy level or a normal patient's level of prolactin. It is lower. Prolactin level is low after delivery if you do it. Now, when the child suckles on the breast, it increases the prolactin. So there's an episodic rise of prolactin when the child suckles on the breast. So that's why continuous breastfeeding, which is hourly to 2 hourly types, like in a day 12 to 14 times of breastfeeding, that kind of breastfeeding most women are not able to do. That's why lactation amenorrhea fails. I was telling you that earlier also. Next question is, laparoscopic tubal sterilization can be done after. Now, if you talk about laparoscopic tubal sterilization, what happens? The uterus is very big, number one. After delivery, the uterus is just below the umbilicus and the tubes are here and they're edematous tubes. So if I put in a scope, one, there's a chance of injuries to the uterus, and it's a very vascular uterus, can bleed like crazy. Suppose you are a very careful surgeon, you've done hundreds of laparoscopy, you don't injure, and you put a clip or a ring. Let's say we do a ring sterilization. So normal fallopian tube is something like this, and you put a fallopian ring here like this. But this is a woman who's puerperal, so the tubes are edematous. They're edematous tubes, and even if you do a fallopian ring application, suppose you somehow do a fallopian ring application on these edematous tubes, so what happens? The edema settles and these tubes will slip out of the ring. So there's a high chance of failure also. So that's why one is, technically it's a difficult surgery to do because the abdomen has a uterus which is at the level of the umbilicus, and if you put in an instrument you may injure. Number two, there's a high chance of failure. That's why we do not do laparoscopic sterilization in the immediate puerperal time. We wait for 6 weeks for uterus to become a pelvic organ and a small normal organ. It becomes a pelvic organ in 2 weeks, it becomes a normal organ in 6 weeks. So we wait for 6 weeks and then we can do a laparoscopic sterilization. So answer D is the best one here. According to the Medical Termination of Pregnancy Amendment Act of 2021, MTP for pregnancy between 20 to 24 weeks needs opinion of one registered medical practitioner, no. Two registered medical practitioners, yes. This is correct. One registered practitioner, no. Court order is required after 24 weeks. That is, you have to first have a board which will have a gynecologist, pediatrician and a radiologist to say that this is not viable pregnancy, and suppose you diagnose a very major disorder like anencephaly at 28 weeks. Patient comes to you only at 28 weeks from a village and you do the ultrasound for the first time. So you know that this baby is not going to make it. So you can do an abortion even at 28 weeks. But a gynecologist, radiologist and a pediatrician has to say that this is not going to survive this baby, and then a government appointed person also has to approve. The board approves and gives us an order, and then only you can do. So none of this is required before 24 weeks. But yes, after 20 weeks to 24 weeks, this is the time when the baby is very big. There are a lot of chances that there can be major bleeding complications, or maybe the MTP may not go very smoothly, and you may have to do a surgical MTP, that is, you may have to do a hysterotomy sometimes. So when you have a complicated MTP, that is, you've done the MTP, there is a lot of bleeding, you need senior people to manage such complications also. That's why 20 to 24 weeks, two medical practitioners should involve and take a decision and conduct the medical termination, whichever method they're using. So that's why two registered medical practitioner, choice B is the best answer for this one. The Combi Pack approved by the Director General of Health Services for medical method of MTP, that is, till 9 weeks we can do the medical method. Of course, if you do till 7 weeks, it is 99% successful. If you do till 9 weeks, then it is 95% successful. So this, when it is done in the first trimester, comprises which of the following combinations? It is mifepristone and misoprostol. Mifepristone is antiprogesterone, it kills the baby, and misoprostol is the prostaglandin, it expels the baby. So mifepristone is given orally and misoprostol is given vaginally. So 200 mifepristone and 800 mg misoprostol. It is the first one itself. We can give 200 to 600 also if it is slightly higher time of pregnancy, let's say 9 weeks, at least 200 of mifepristone, 800. So this is mifepristone given orally, antiprogestin, which kills the baby. Misoprostol is given vaginally. It is a prostaglandin which expels the baby. So A is the answer. The rest all choices are not correct. So that was the last 2-3 questions were the easiest in the UPSC exam, and there are a lot of questions which tested our knowledge about the basics, the basic sciences, and that's what is the fun of writing the UPSC exam. It's a very good exercise before you write the major exams like the NEET exam which is coming up. So keep staying connected with us on the PW forum for a lot many question answer series, and looking up for the NEET PG marathon which is coming up. My discussion with you is on 24th of August. So see you then with the NEET PG marathon. We'll do all the marathons before the exam so that we can do as many questions as possible. All the best, guys. Keep reading very hard.